suppressed the virus. Welcome to everybody that's attending, all of our speakers. This year, today actually, is the 1 year anniversary of the first lockdown. And this is a year of, in the past, complete failure with 140,000 dead, untold numbers with long COVID, and an economic disaster that's already created another 1.4 million unemployed. Now, other countries did not experience these disasters, and today we want to highlight why and how we can emulate their success. The meeting's going to finish at 8 p.m. today, so just so that all the speakers where I am going to be quite strict on the timing, and the hashtag for anyone on social media or Facebook, Instagram or Twitter is hashtag a year of COVID failure. So I'm going to hand over quite quickly to our first speaker, who is Professor Aoife McLysicht. Aoife became a star of our last public meeting by drawing an analogy between zero COVID policy and zero fires policy. That clip got 57,000 views on Twitter alone, and this evening she will explain to us how in Ireland, after a good beginning and a very poor middle, the current situation has improved again, and what steps were taken to achieve that. Aoife.
Thank you very much. Thanks for the invitation. So I'm glad the zero fire analogy made sense to people. I think it is hard sometimes to explain what we mean by zero COVID. But yes, so I think I'll give a brief description of the situation in Ireland, which is not ideal, but not the worst either. So, we did really well last year. Our government reacted relatively quickly to put in a lockdown, which was very effective, got the cases right down. But the problem was they didn't put in the non-lockdown measures. Basically, our public health units are not well resourced. Certainly, they're not as well resourced as they are in the UK, which means that we still don't have, for example, retrospective contact tracing. So we don't know where people catch the virus. Our public health doctors are kind of hobbled by lack of resources and lack of status and things like this. Just today, we brought in mandatory hotel quarantine. So that just started today. It was requested May last year by the advisory committee that are advising the government. And it looks like it's got a lot of holes in it as well. So what's happening now in Ireland is the population as a whole are pretty good in that people agree that this is a problem that needs to be dealt with on the whole. So we have a very good situation from that point of view. We don't have a population who's dismissing this problem. The population in opinion polls, we keep seeing that people want, they don't enjoy, they don't relish the restrictions, but they understand they're needed and therefore they accept them and they want them. But the government isn't doing their part. So we're currently in a situation where we're in a new lockdown after Christmas because we opened up for Christmas, which led to our worst crisis, so our third wave. And what's happened now is we have the B117 variant that, of course, was first noticed in the UK, but it's in a lot of countries now. And it is more contagious, as we know, and it has not responded as well to the lockdown as the older variant. So we've kind of plateaued out at a high level, a level that isn't really tolerable in our country. And it looks like we're now in an interminable lockdown because we're only just holding steady and we can't release anything because doing so will send us back into exponential growth. And our government doesn't really understand what they are lacking, what they're missing. And part of the reason they're not understanding is because they haven't done the basic public health stuff to really find where the infections are happening. We strongly suspect that, we know in every country, we see the same pattern. Where you have cases, they're even more concentrated in areas that have a lower average income. So you have people who are living in worse accommodation and worse jobs, and these things correlate. And so we have there are people who are living in cramped accommodation. They're asked to isolate, but they have nowhere to isolate. So it's the essence of mismanagement of the pandemic is asking people to do things they can't do. And so the government isn't recognizing this at the moment, and these things are not, we lack this joined up thinking. So we are pushing to the government to recognize this. In certain ways, we've been successful in that we have the government now talking about zero COVID. They had a press conference earlier today and they talked about zero COVID to say how they weren't doing it. They talk frequently about how they're not doing it. The problem is they won't yet say what they are doing. They haven't told us, we haven't got an articulated strategy, so it's kind of leading nowhere. So that's our situation. We've been, we've got this We Can Be Zero campaign, which we have, we are encouraging others to join in. We actually think that because of the common travel area between Ireland and the UK, and because of the difficulty, of course, in managing the northern border here in Ireland, that the most stable strategy ultimately would probably be a coordinated strategy on these shared islands. Because one of the things that we do need to do to get this under control is have proper effective quarantine for people coming in, because we can't keep burdening the public health units with more and more cases coming at them for every direction. And of course, as we know, some of the variants that have arisen around the world are variants of concern in terms of how they are covered, how they cause disease, the increased morbidity, and what they do in terms of how they respond to the vaccine, or how the vaccine can protect against them. So in Ireland, we're currently in this plateau. Effectively, we're kind of stuck because our government hasn't yet decided or agreed to take the next step to make this lockdown more effective. Some of those steps would include addressing marginalized communities and engaging with them, and they haven't yet agreed to do that. We keep trying though, and we think that if there was some movement in the UK as well, that would be really helpful for us. I think we all benefit. I think that's a very nice theme from today's meeting, looking into different countries, because I think we all benefit from hearing that there will be similar actions in other parts of Europe. Of course, we know in further flung parts of the world, they've done this really well. And they, I think, also benefit from having each other to compare to. So I won't go on. I know we're tight on time. I don't think there's any viral clips in what I just said, so not from this time. But it's great to talk to you, and I think this is a great idea to get different people from different countries talking about what's going on.
Thank you very much, Aoife. It's always great to hear from you. Our next speaker is Professor Walter Ricciardi. He is the Professor of Public Health in Italy, and he's going to explain to us the factors involved in what is now, unfortunately, Italy's third wave. Walter.
Yes, actually, the situation in Italy is pretty much similar to the Irish one. We are experiencing a very violent third wave with the highest number of deaths in January, more than 500 deaths just today. And this is happening, of course, because of the B117 variant, and also because of a kind of reactive approach of the Italian government. I am advising the Minister of Health, and he's very sensitive to a proactive approach, but unfortunately, the Italian government at the moment is a coalition government with different parties with different sensitivities. And my advice has been instrumental in resisting to opening everything, which was the desire of the mostly center and right-wing forces. At the moment, 42 million of Italians out of 60 are in areas which we call red zones, which are restricted mobility area, but not exactly the kind of lockdown that we experienced in March, when you remember Italy was the first country struck by the virus outside China. So there is a difficult relationship between science, politics at the moment. Even though I'm a strong advocate for zero COVID, no COVID, or what I can call stop COVID strategy, I think it's very difficult for politicians, at least in Italy now, to adopt it. But I have had conversation with advisors of the governments in other European countries, mostly concerned about the situation, but relatively unable to advise governments to go in the direction of no COVID. And this is particularly true for Germany. You know that Germany was on the verge of applying this strategy, but we will listen later. I understand that something happened that made this not possible. I hope that in the future, this kind of international collaboration will push in the right direction, because certainly a government would be encouraged to go in the right direction if other governments do that. I will conclude saying that at the moment there is the rhetoric of mass vaccination, as the final weapon of liberation, which I try to convince that this is not true. And there is the example. So we are talking about UK. At the moment in Italy, UK is very much cited as an example of solving the problem. It's very difficult to make people understanding that you, as far as I know, you are in a lockdown since November, and that of course mass vaccination in UK has been very effective, but it's just with a combination of different tools, of different public health and vaccination activities that we will get out and we will go back to normality. I hope that this international movement will support all of us and will bring us in the right direction. Thank you very much for your attention.
Thank you very much, Walter. Our next speaker is going to be Dr. Thomas Ryan from Trinity College in Dublin. Thomas will speak on the public health measures needed to prevent the emergence of a new and potentially even more threatening strain of the virus. Thomas?
Thank you very much. I'm here with Professor McLeisett, representing the Independent Scientific Advocacy Group in Ireland, which is modeled on Independent SAGE in the United Kingdom and is advocating for an evidence-based response to the COVID-19 pandemic in Ireland with a focus on a zero COVID elimination strategy. Professor McLeisett already gave a very succinct summary of the situation in Ireland, where we are and how we got here. With respect to new variants, this is something of very significant concern in the media and in the public conversation in Ireland today. At Christmas, we had a premature opening of the economy. We had just entered what was clearly our second wave, really starting in August, but it started to become very apparent to most of the public by the end of September. And then we entered a 6-week lockdown, which was focused on dates, unfortunately, and not data. And the government had the rather unambitious target of opening up, hopefully for Christmas, at 100 cases a day. By the time we were 6 weeks into our second lockdown, the government decided to open up at what was about 200 to 400 cases a day. And it was a perfect storm, because first we opened up hospitality, and then 2 weeks later we opened up home visits. And it led to a very disastrous third wave in Ireland, which has so far caused more deaths than the first wave. It also has resulted in us being in an extremely long lockdown, which we will be in at least until the end of April, probably by any standard. Now, one feature of this was that it introduced the Kent variant, the B117 variant, to Ireland. There was some international media narrative that this had caused the Christmas surge in Ireland. That was what the government were trying to put out at the time. It's completely clear that B117 did not cause the Christmas surge in Ireland. However, the Christmas surge in Ireland allowed the B117 variant to rapidly become dominant in the population. What was particularly unfortunate was the writing was on the wall by December 15th, based on referrals to general practitioners, based on the rapidly rising number of tests of COVID-19, of SARS-CoV-2 positive tests. And by December 22nd, we knew that the B117 variant was in Dublin. And yet no measures were taken to mitigate its spread around the country over the days surrounding Christmas. The government took it as a set menu until Boxing Day, St. Stephen's Day, when we started to impose restrictions that we anticipated would be required on New Year's Day. The B117 variant became dominant by the end of January, and this was as a result of our post-Christmas lockdown for suppressing the wild-type variants, but not sufficiently suppressing the B117 variant. And it is now nearly 100% of the virus population in Ireland. The good news is we are containing it. This lockdown, though, it's not quite as strong as the first lockdown. It did have schools closed until last week when we opened primary schools. And we were having a slow decline of the B117 variant in Ireland. Unfortunately, then there was a plateau for many weeks, and right now we're worried that it's starting to go up again. What we can learn from this, however, is that introduction of new variants to Ireland can happen very quickly and can have a devastating effect. And we saw this last summer too, because although we never actually had zero COVID in terms of tests per day by any standard, we got down to a handful of positive cases per day. And genomic analysis, quite comprehensive genomic analysis that was done on SARS-CoV-2 in our second wave, has shown that virtually all of the SARS-CoV-2 variants that were there in our first wave were actually eliminated by our second wave. So although we never got to full zero COVID, it seems that the tails of the first wave did in fact die out based on restrictions that were lingering through most of the summer. And the second wave was entirely seeded by new variants that came in June and July and September through international travel, and principally the Spanish variant at the time. I forget the exact notation of that variant. So twice in Ireland, we have seen that international travel has been a game changer in our experience of the pandemic and in undoing all of the work that we've put in through lockdown. We're now in our third lockdown. It is the longest. Many would argue it's been the most challenging on the population. And of course, the conversation is quite muddled because of vaccine optimism. And it should be said that, in Ireland, we actually have a large degree of vaccine take-up in general. And so we don't have a lot of vaccine skepticism by any standard. However, we are concerned with the new variants, particularly with the reports of how the South African variant does not seem to prevent mild to moderate illness, or the AstraZeneca vaccine seems to not prevent mild to moderate illness when people are infected with the South African version. And of course, we're very concerned about what's been happening in Brazil, and particularly in Manaus. Now, we know that both the South African variant and the Brazilian variant, the P1 variant, are in Ireland. We also know that there have been cases of these variants from community transmission, or what our Australian colleagues will call mystery cases, rightly called mystery cases. So we don't fully have a handle on these variants. And it has been reported that there has been a school outbreak yesterday of the P1 variant, although as far as I'm concerned, the details still need to be confirmed regarding that case. Today, we had international hotel travel quarantine put in place for the first time. It is the most rigorous regime in Europe for it. It's also completely inadequate because we are only applying it to 33 countries as a point of origin. We're not really checking where people are coming from, so people have to self-declare their origin. We have 8 group types of travelers which are excluded from the requirement to hotel quarantine, including politicians, even if they're not in government. And we are doing really nothing about people coming from any other travel origin. And we know a lot of people have come in from high-risk regions in the past few months and have not been properly isolating at home. So in conclusion, what we've learned in Ireland is that you can eliminate the virus in Europe. We did eliminate the first variants in the first lockdown. We learned that late. We squandered the opportunity of being an island. Part of the reason we were able to eliminate it is because there was very, very little travel into Ireland during the first lockdown. And of course, the first lockdown was so severe that people who did fly in didn't really have anywhere to go once they were here. We would have had a zero COVID island, but then we allowed international travel to take over. We've also allowed international travel to bring in new variants, which has completely changed our experience of the pandemic. And we don't know what it's going to be like to open up with the B117 variant in the population. So I'll just close with saying that it's very clear that international travel restrictions is absolutely key to managing the situation. Ireland is a case in warning of lost opportunities. And this, in combination with sensible restrictions and comprehensive reverse contact tracing, which we don't have in Ireland at the moment, are absolutely crucial if we're going to crush, contain, and chase the virus from the island. Thank you very much.
Thank you very much, Tomas. And continuing on with another speaker from the EU, we have Professor Matthias Schneider, who is a professor of medical and biological physics in Dortmund. Where is Dortmund, you ask? It is in Germany. And Professor Schneider has a strongly argued rather for a strategy to achieve zero COVID, not just an endless cycle of lockdowns and reopenings. And tonight he's going to outline that argument for us. Wie geht's, Professor Schneider?
Ausgezeichnet. Very good. Thank you very much. Do you should I share some slides or should I just start? I have some, but I don't really need them. If that's
No, that's absolutely fine. Up to you.
okay. Maybe I share. If you don't have, if it's technically not a problem, then if it works right away, we do it. If not, can you see that or can't? No, you probably.
Yes, I can.
Do you see the whole thing? Yep. Okay. Yeah. Thank you very much for having me. Yeah, we started. I mean, I could repeat a lot of things what Thomas just said, you know. But well, maybe I should start with that. I think in Germany, unfortunately, is not just international traveling that has mismanaged, but it's mismanaged on all ends. I think we are living through a complete failure of our, not just the government in Berlin, but on, you know, in all states. It's very frustrating to see, and I want to go through, want to guide you through this, how we try to keep our hopes up to do something. But politics is it's rough right now. Let's put it this way. So we are an interdisciplinary team that formed out of mid-air 2 months ago. We have virologists like Melanie Brinkmann, and we have 3 physicists. One of them is myself. But we have medical doctors and also economists and people who study families and children's and schools and stuff like that. So we're trying to cover all the fields, because obviously this is something that affects the society, not just the hospitals, which of course is like terrible, but it's not the only part. The children in particular, of course, suffer a lot. The strategy was very early on, was like, we want to learn quickly. We want to have, with this multidisciplinary team, we want to learn from those who did it well, who did it right, like the people in Australia and New Zealand. And the key role was Janir, which I'm glad to see that he's here as well. I got in touch with him nearly a year ago, and I this is how I learned all about the green zones and the theoretical background. And Stephen and Michael and Aistis and Janir, they are all part of our external advisory team in Germany, and they helped us a lot. And I have to really thank all of them, especially because, you know, the success of from the political side was frustrating. We still try to continue to solve issues, so we are trying to still focus not too much on campaigning, but still trying to bring out scientific input, but not scientific input in the sense that we do research, basic research for like how to study the virus, but rather for creating toolboxes that can help, that can empower local states, local counties, and and so on, to realize their ideas. So by the end of the day, and I think this is my key message, this is the only thing that seems to work. We continue to debunk myth, but to make a long story short, we actually try to focus on the locals right now. So we try to focus on counties. We're trying to focus on even smaller levels than counties, like what we call this, like local communities and so on. And one of the reasons is a selfish reason, also because it's so much more rewarding, because if you talk to people on a local level, you get a feedback, because they immediately understand if they do it the way. Because I think we all agree. I mean, especially after hearing Thomas, I think we completely agree. It's clear how it needs to be done. There's one winner strategy. 23 million people living without the virus, or living with under a lot better conditions, and those are all countries that went for zero or no COVID. So and so there is one loser strategy, living with the virus, and there's the winner strategies, they're getting rid of it. So but how do you get the frustration out of the people? And there's a lot of talk in Germany that people are tired of pandemics, and this is I would be also very careful with the sentence, because a sense like this can also easily become a self-fulfilling prophecy, because what I can tell you, that if you talk to the locals, they do everything they can to do something. They wait for people like us to give them some kind of tool so they can do something. And I can give you a specific case in a second. One way the way we are trying to empower and mobilize the local communities is by showing them this kind of map. So this is Saxonia in the summer in green and yellow, and this is Saxonia now on the right side. And you see a big difference depending on how you present the data. On the first slide here, let me get my pointer so you know where I am actually at. Here, you see it on the county level. Counties are typically in Germany about 200,000 people, and everything seems red, which means it's like you are somewhere in a 7-day incidence of between 30 something and 100. And darker is even worse, of course. But if you go on a more local level, if you do a more finer resolution, then you see that there are a lot of green spots over here and everywhere. And I think people need to know that. They need to know it's not all over. It's not completely hopeless. And then a second point that I learned early on from Janir was that once you go down with the numbers, once you get low, you need to be aware of the discrete character of the numbers. Because for a community which it's probably 60% of Germany, people live in these small local communities. If you, let's say, with 1,000 people that are living there, if you go from zero cases to 1, you go from 7-day incidents from 0 to 100. And 100 is very alarming, and 0 is obviously the best you can have. So it doesn't make any sense to do these averages per 100,000 people. So we actually have to, we are trying now to get together with people that scrap and grab the data from everywhere to get a much more finer resolution on what the situation in your community really is. So what is really the situation where you live in this, because if you look at mobility data in Germany, 80% of the mobility that is done in Germany is done within your little county. You don't cross borders much naturally, and 20%, the other 20% that are crossing the county borders, 80% of those, so 60% of the total pie, are actually people that commute to work, which is something that's fairly easy to control, because companies aren't the issue here. And the companies have a much better testing system going on than the government has, and for example, as the government implemented it in schools. So there's only a few people that really, if you put it that way, it's only a few people that really cross the county borders. So you need to tell the people in their little counties, in their little communities, you only have 2 infections left. Forget your stupid number of incidents. You have 2 infections here, get rid of them, and you are fine. And make sure you protect the state, of course, the way, that's the whole green zone model idea. So, and if you do the math for Saxonia, which is 4 million people, 1 million of Saxonians actually live near a local communities, and a week ago it was 1.5. Numbers go down, unfortunately, quickly, because, you know, you might have heard that Germany decided to reopen and now they decide to close again. So we have this whole like up and down kind of situation, which is the worst of all combinations that you can have, of course. So this is terrible. So this is the one thing. Tell people what's your local situation. And the second thing that we are trying to focus on now is to utilize the climate and the structure of universities. So I personally went to the head of my university, the president in Dortmund, and I told him, you know, you're a physicist, you know, he's a physicist, and I told him, you're a physicist, you know what's going to happen. They're going to open and they're going to close again, and then they're going to open again and they're going to close again. So we're going to have another terrible semester, which is going to start in Germany on April 15th. So that, like, if you want to do something, this goes like 3 or 4 weeks back. So we need to get into action. Forget, you know, if you wait for the government, you wait for it's not gonna work. And so I was able to convince the head of our university, which we have like 30,000 students. It's not huge, but it's like, and the city has 500,000 people. So it's not huge, but it's a decent sized city and a decent sized university. And we got it rolling, and everybody pulls along. And the message that I want to, maybe, I don't know if maybe it's old news for you, but what I felt like, no, these people aren't tired. These people are incredibly happy that people like us come in and tell them we can do something here. We can get a university campus green. And it's not the same kind of green as in a community, because the people don't really live there. A lot of people commute. It's more like the model that you might have heard from Cornell. So you do a heavy duty testing. You test them at home with antigen tests. You test them with PCR on campus. We are planning right now, we do test them 3 times a week, the students. And as you know, comparing the money that you throw at such things compared to a lockdown is always cheap. It's always better to throw money on things. You know, it's always cheaper. So we convinced the chancellor of the university to pay the bills, and we started actually. Here are a couple of reasons why I think universities are a good idea. You have a smart clientele. They usually understand. It's easy to communicate with them. That you have labs and scientists. So you have a campus structure, which helps to organize everything. And you have adaptable teaching protocols. So you're not dependent. You don't deliver to another like a couple of companies that rely on each other. You don't really deliver. If you have a little outbreak, you shut down for a week or 2. So you're much more flexible and can adapt to the situation. And students are super excited. So if we send around, like, we need some students to set up the tents for the testing, it usually takes a couple of hours to have like 50 or 60 students in presence. We always have more students than we need. So and of course, it doesn't cost money, but it's also, they're usually smart and creative and solve the little issues much faster than the people in the administration. Yeah, and here are a couple of pictures. We have we started last week with the testing. So we are right now on break. So we don't have a lot of students. We started with just with one lab last week, like a bunch of students that had to do a chemistry lab, like 20. And this week we test multiple days. We do pooled PCR twice a week.
Professor Schneider.
Yes.
Sorry, I'm going to have to ask you to wrap up if that's okay.
Yes. That's the last one. That's the last one. So and then so we also try to encourage the people to really come to testing, and once it runs, we hope we can also catch the city, and so I think that the point is that I want to get across is that don't forget the little things. Start from local and try to grow big. I think that's my last hope I have. Thank you very much. Sorry for being a little long.
No, it's okay. Thank you very much, Professor Schneider. It's fantastic. Our next speaker is Helen OConnor, who is a representative of the GMB union and a nurse. She shared her views with us at previous meetings, and tonight she's going to focus on how the failure to suppress the virus has impacted medical professionals on the front line and how they are treated more generally. Helen?
Thank you very much, Bal, and thank you for inviting me to speak. So I think it's important to start by making the point that the NHS in the UK was being dismantled by stealth before the pandemic by a combination of defunding of services and privatisation. And this created drastic cuts in bed capacity and staffing in the NHS. And in spite of the pandemic, the cuts and privatisation agenda of the Tory party has not lessened, it's actually accelerated. And this has manifested itself in the billions spent on private contracts and the restrictions now being placed on access to NHS services. And cuts are being made, but right now, via the rollout of the integrated care system model, the digitalisation of NHS services, and hours are being stripped out of contracts by private companies operating within the NHS. And throughout the pandemic, the vast majority of GMB members, the nurses, the cleaners, the porters, have been physically present in the workplaces. And it's our members who've kept the NHS running, and they've all played a key role working together to save the lives of some very sick people. And very unwell people require extra care, so workloads have increased even more. And for infection control purposes, the hospitals should be cleaner than ever before, but unfortunately they're not. And our members have worked under grueling conditions, and many have become unwell with COVID-19 themselves, and they've been pushed to work in unsafe environments without the quality or the quantity of personal protective equipment that they've needed to protect themselves. And in this country, we've seen up to 1,000 NHS workers die from the virus. And I'd love to say on this anniversary of the pandemic that our members are being properly supported by employers in the NHS, but this is not the case. And there is a persistent and stubborn unwillingness to amend the Public Health England guidelines on the PPE. And to this day, the quality of the personal protective equipment available for NHS staff is still really poor. And they've made so much sacrifices, the NHS staff, to get this country through the pandemic. Some have stayed away from their families for weeks. They've had annual leave cancelled. They've had rest days cancelled. They've coped with the severe staffing shortages already caused by the chronic NHS recruitment crisis, but it's been exacerbated by unprecedented levels of staff sickness as well. And the pandemic has utterly changed NHS workers and nurses in particular, and the grassroots UK NHS Pay 15 campaign sprung from an NHS workforce that's been shaped and politicised by the impact of this pandemic. And a whole new wave of NHS workers have had enough of their goodwill being abused, and they're getting active in their trade unions, and they're seeking answers, and they're making demands. And hundreds of conversations are happening around the prospect of organising strike action in the NHS. And in the GMB union, we'll be educating our NHS reps, and we'll be answering their questions in an open and honest way, because it's not our intention to hold back struggle, because we recognise that if NHS workers continue to be mistreated, patient care deteriorates. It's as simple as that. So it's far better from our point of view to take strike action in the NHS for a limited period to protect staff than lose the NHS for good, because that's what's happening, because mistreating and demoralising NHS workers is part and parcel of the cuts and privatisation strategy steamroller that's crushing the NHS. And the last thing I want to talk about is how we support working class people to fight for their rights during a pandemic, whilst maintaining a zero COVID position, because the two can seem like they contradict each other, and tensions are building underneath the surface between maintaining public safety and the need to build an organised, coordinated fight back to protect people. And what we want in the Zero COVID Coalition is the maximum health and safety measures in enclosed spaces and genuine efforts to suppress the virus. But the priority of our government has been and always will be to prioritise building the profits of big business at the expense of protecting public health. And we've seen during the pandemic that not one employer who's been negligent and breached COVID restrictions has been prosecuted. And in the meantime, our civil liberties are under assault like never before, which was clearly demonstrated during the peaceful vigil on Clapham Common for Sarah Everard. And our ability to support people to fight for their rights is being stripped back even further via the police bill currently making its way through the Houses of Parliament. And right now, our members are under attack like never before. And in Lewisham Hospital, for example, workers are going through another savage round of cuts as 495 cleaning hours are being stripped out of Lewisham Hospital. And yes, it's happening right now in the middle of a pandemic. So this should demonstrate to anybody that cutting the cleaning doesn't even matter during a pandemic in a hospital. Millions are being laid off from their jobs, and the mass poverty and the type of conditions that accelerate the spread of disease is on the cards for many. And building strength, confidence and solidarity via the democratic right to peaceful protest is a key method to enable working class people to fight back against the government. And as a movement, we cannot afford to become divided on this issue. So across the unions, we must engage in discussions around a united strategy that enables the labour movement to support all categories of working class people, whether people are physically in work, whether they're working from home, or whether they're losing their jobs. And we must support effective resistance to the jobs and public services cull that's happening right now that will affect all of us in society. People will want to get out onto the streets. They'll want to get in front of workplaces to protest and demonstrate in a safe and risk-assessed way. And we've done it before, and we can do it again. Other workers will want safe, risk-assessed home working, and we need to support all of them. And we should endeavour to do it in a way that unites us and that builds power for every last worker in this country. And we need to continue to organise effectively in our trade unions and in our communities to win the type of society that working people need and deserve. Thank you very much.
Thank you very much, Helen. Our solidarity to all the GMB members and the nurses across the country who are currently standing up to the pitiful excuse for a pay rise that this government has said that they're going to give. Our next speaker is Ben Chaco, who is the editor of the Morning Star and a pillar of the Zero COVID Coalition. Tonight, he's going to be talking to us about why different countries have experienced such different outcomes in the pandemic in terms of deaths, and talk to us also about vaccine hoarding and vaccine nationalism. Ben.
Thanks very much, Belle. And I'm sorry I've only just been able to join the call, but we've just gone out to print with our splash on the brilliant news about the Shrewsbury Pickets victory today. So a great day to be working at the Morning Star. I thought I'd begin just with something I noticed in the news earlier this week, that there was an appeal from Chinese health officials for people to register to take the vaccine in China. And an official of the National Health Commission there, He Qinghua, said, many people mistakenly believe there's no practical meaning to being vaccinated because the epidemic has gone away. So Chinese officials are worried that the country's very success in suppressing COVID-19 is undermining the vaccination effort, and the official went on to explain why it's really important to get vaccinated and encourage Chinese people to do so. But I thought it was an ironic episode, given that attacks on zero COVID campaigners in this country typically accuse us of wanting endless lockdowns and restrictions. But what that experience in China has shown us is that in countries that adopted a zero COVID strategy, we see that they've so lifted restrictions that people are actually now very complacent. They feel that things have gone back to normal. So life can get back to normal, and you can carry out your social and economic activities without a high risk of catching COVID-19 if a country has adopted a zero COVID strategy. We know that the number of lives saved through zero COVID strategies is extremely high. Just to take a handful of examples, we know that the death rate in Britain, 126,000 people have died from COVID-19, with a death rate per 100,000 people of 190. We compare that to several zero COVID countries. Thailand, a total death toll of 90, that amounts to 0.13 deaths per 100,000 people. In China, 4,839 deaths, 0.35 deaths per 100,000 people. We have 0.04 deaths per 100,000 people in Vietnam, and 0.53 deaths per 100,000 people in New Zealand. So literally tens and tens of thousands of lives have been saved by countries that have adopted this strategy. But what we're seeing is that they're not saved by imposing endless restrictions on everyone. They're saved if you adopt a strategy which allows restrictions to be lifted much more quickly than ineffective half lockdowns as those we've seen in Britain do so. So just quickly, how are these results achieved? Precise strategies varied from country to country, but the main elements of a zero COVID strategy are actually quite straightforward. Lockdowns should be designed to minimize all unnecessary human contact. So in New Zealand, non-essential work was stopped, including in sectors like construction. While in Britain, the rule has been that you might be advised to work from home if you can, but if you can't, you have to continue going into work, whether or not your work is essential. An enormous leeway has been given to management to decide whether your presence at work is required. The Health and Safety Executive has not been resourced to police this at all. So as Helen mentioned, there have been no convictions at all. As a result, a huge amount of unnecessary human contact has continued in Britain. We've seen the consequences in outbreaks in Leicester garment factories, issues like gas workers being sent into other households, not to carry out essential repairs, but just to read meters, keep profits flowing. So when it comes to schools, Britain's policy has been very variable, whereas in New Zealand or China, it was taken as read that during a lockdown, these have to close because virus suppression is the absolute priority. Zero COVID countries also took a far stricter approach to monitoring international travel, testing at airports and quarantining arrivals, something that wasn't done in Britain until around 10 months after the first lockdown was announced. So that's one aspect of it. Then there's test, trace, isolate and support. We know what a botched system we got in this country, and that was to do with the whole privatization model that we've had in this country, where you ask private profiteering companies to bid for these contracts. In Britain, the cronyism, the chumocracy we've seen with the Tories has made that even worse. But in East Asian countries, including China, but also South Korea and Taiwan, mass testing and contact tracing was delivered earlier through digital apps often that tracked infection status and people's movements. There were some concerns over privacy and so on, but these were adapted also in Western style countries like Australia, where phones would contact each other and you'd be able to digitally trace where people had gone without the kind of more cumbersome contact tracing approach that we've used in this country. But aside from that tracing process, effective support was deployed, real support for every worker who can't go into work at the moment. And also, I've got several examples, but I'm running out of time. So there was a much more thorough approach to supporting people who are unable to work, to allow the lockdowns to work. There was much more effective public messaging, particularly in New Zealand, where everybody was got on board through community centres, through churches, through mosques, to make sure that the message was understood by the entire country. In Britain, we had even devolved governments complaining they were not consulted or informed in advance of what government policy is, and we had ministers bickering on TV about what the rules meant. There was absolute confusion, and that resulted in chaos on more than one occasion. So those are all examples of the kind of policies that allow a virus to be suppressed. What we're seeing now in the final part of this address is the rollout of a vaccine, which is being treated in some countries as a solution to the entire problem because they have the levels of infection are still very high. But the tragedy is that the same countries that have not been able to suppress the vaccine are now undermining the global effort to suppress the virus. Vaccine nationalism and vaccine apartheid is seeing all of the vaccine doses monopolized by a handful of wealthy countries. We've seen companies like Pfizer accused of bullying Latin American countries, charging them through the nose to get access to vaccines. In a horrendous story last week, we saw a huge shipment of fake vaccines seized in Mexico on its way to Honduras. People are so desperate for these vaccines because rich countries have bought up the entire supply, that criminals are able to deploy ineffective and possibly dangerous vaccines to a ready market in the third world. So it's absolutely essential. I think there are all kinds of political messages for us and lessons from the way that Britain has mishandled this virus. There are lessons in terms of public ownership, public delivery of public services, and the rampant corruption of our political elite that need to be addressed. But we absolutely need to stand in solidarity with third world countries as well and say that the monopolization of vaccines by wealthy countries is absolutely not just absolutely immoral, but will undermine our own effort to recover from this virus. Because as we see with the mutant variants that are emerging and re-emerging across the world, unless the vaccine is suppressed worldwide, we can't suppress it in this country either. It will keep coming back. I'm very sorry to have gone over time.
Thank you very much, Ben. And on that point, we are literally going across the world, where we are delighted to be able to introduce health economist Stephen Duckett, all the way from Australia, where it is literally already tomorrow. Stephen will be able to bring us some good news. Not only is he the Programme Director at the Grattan Institute and former Secretary of the Commonwealth Department of Health and Ageing, Stephen is also one of the key architects of the successful Australian zero COVID policy and will explain that success for us tonight, although it's tomorrow. Stephen.
Thanks very much, Diane. And it's great to be with you to share what's happened in Australia. Listening.
I think we've just lost you there, Stephen.
Announced yesterday that one of the important religious events that occur in Victoria, namely the footy, is going to be back on track. So they announced that the capacity limits for the main stadium will be 75,000 people from Friday night. So we are living an absolutely normal life. I have to wear masks when I go on public transport. If I go to a restaurant, I have to click in a QR code. There's capacity limits on offices, but basically we have zero virus circulating in the community. So how did we get there? The first thing is we imposed strict external border controls more than a year ago. We were one of the first countries to impose border controls in the world back in February, I think it was, 2020. Secondly, we had internal border controls. We had green zone states and we had red zone states. And where I lived turned out to be a red zone state critically in the middle of the year with a second wave. And the other states closed their borders to us. And so we couldn't travel. Thirdly, we also had intrastate border closures. So the city of Melbourne, for example, I couldn't travel to rural Victoria. Fourthly, the government had a social license to act. The public was fearful of the virus. They started restricting their own activities before the government imposed restrictions. And so there was important community support, community solidarity about responding to the ravages of the virus. Also importantly in Australia, the political spectrum is limited. We did not have the loonies of the COVID deniers. Basically, all of the mainstream parties, not all the MPs incidentally, all of the mainstream parties were recognised the issue of COVID and thought that we should do something about it. There was divergence in opinion across the country about how strict we should be, how strict the lockdowns should be, but there was consensus that a public health response is the critical thing to do, and that, especially in Victoria, a public health response was also the best economic response. People don't go out and buy things if they are fearful of dying. So there was very strong consensus that the right thing to do was a short, sharp shock, a lockdown to actually eliminate the virus. Here in Victoria, I was in lockdown in this office, in my home office, for 110 days. I was only allowed to go outside 1 hour to exercise. I could go out to shop. I could go for medical appointments, and basically that was it. We were and there were curfews and all sorts of other things. So, but that was strongly supported. Incidentally, politically, the governments which managed the virus well have been returned. The Western Australian election was a couple of weeks ago. The government, the Premier had a popularity rating of 90%. The opposition party was decimated and now has 2 representatives left in the lower house of the Western Australian Parliament. Importantly, there was some debate about how strict we should go, suppression versus elimination. Both sides, though, were really clear that they wanted to make decisions based on the scientific evidence. And so the public health officials, the chief health officer, were up there in the media every day. So in Victoria, the Premier had a press conference every morning at 11 o'clock. Standing next to him was the chief health officer, and just total public transparency about where we were going, how many cases, and so on. So the target was to get to 0, and we had daily reporting about how we were going there, how many mystery cases there were, what was being done, and we all knew what the target was. The government published the targets, published what we could, when we'd be, restrictions would be relaxed at particular levels and so on, with the aim of absolutely getting to zero, which is where we have achieved. And of course, when it was announced we got to zero, people who were driving cars tooted and all those sorts of things. There was a huge, masks were mandatory both indoors and outdoors for a while during the lockdown, and indeed after. It's only just been recently that we haven't had to wear masks in supermarkets. Importantly, there was free testing of the right from the start. Also compensation if your workplace didn't provide you compensation for having to stay at home. There was government compensation for staying at home, so that it made it possible for people on low incomes to be tested and not starve, basically. So one of the critical things also I want to mention is clarity of the objective right at the start about what we're trying to achieve and where we're trying to get to. Not everything was perfect by any stretch of the imagination. We had we have 2-week quarantine for international arrivals in hotels. They weren't always perfect, and so in fact our second wave in Victoria was caused by a breach of hotel quarantine. But nevertheless, so that's a good part of hotel quarantine, but a bad part that it actually breached and we got community transmission. There was some aspects of Australia's multicultural society which didn't work well. When we closed down a housing estate, there were very poor communication with the residents of the housing estate. The Commonwealth state cooperation was variable, to put it mildly. And we're now just rolling out. We delayed the rollout of the vaccine because the virus is not circulating. We didn't need it as urgently as they did in the UK and the US, for example, but the rollout of the vaccine has gone very poorly. So overall, Victoria's a success story. That's not to say there weren't elements of disadvantage. Mental health issues, domestic violence issues, alcohol and drug issues, anxiety amongst kids who couldn't go to school. They had a terrible 2020. But nevertheless, overall, the economy is bouncing back. We have no COVID in the country, and we're on our way to being vaccinated now. And so we'll be able to return to even more normal with opening the borders. Thank you.
Thank you very much, Stephen. And that is good news for Australia, indeed. If only we could have the same here. Our next speaker is none other than Diane Abbott MP, who has been leading the way on zero COVID here in the UK, and she'll be talking about how discrimination and equality have been made worse in the pandemic. Diane? Diane? Oh no, I think Diane is still on mute. So just to keep us to time, I'm going to go to our next speaker, who's Dr. Colleen Flood. Colleen is the University Research Chair in Health, Law, Policy and Ethics in Ottawa. And we're delighted that Dr. Flood can share her expertise all the way from Canada. She's going to discuss some of the legal and moral issues raised by the mishandling of the pandemic, including the treatment of elderly people, disabled people, and the inequity in the vaccine rollout. Colleen.
Hi, everyone. I'm actually not in Canada right now. I'm actually in New Zealand, and I'm going to actually speak to you a little bit on lessons both from Canada and New Zealand on COVID zero. I'm a New Zealander by birth, but I've spent many years living in Canada, most recently in the largest population by province, that's on province by population, that's Ontario, but also in the smaller eastern province of Nova Scotia for a while. And as was just mentioned, I'm a health law professor at the University of Ottawa, but I've been back living in New Zealand for several months now. And so I thought, some reflections on the comparison, particularly between Ontario and New Zealand, might be helpful. And I think, you know, I'll just start with something blindingly obvious to all of you, because we're sort of speaking to the converted, but perhaps not to everybody else. And that is that countries that have aspired to COVID zero have fared much better than those who have not. And my friend and colleague, Stephen Duckett, was talking about Australia just now. And I believe this is the case not only in New Zealand, Australia, but all countries that have aspired to COVID zero, that normal life has largely been restored. Restaurants, schools, events, sporting events, businesses are open, and all these economies are faring relatively well. And so I think when we, you know, look at this issue, from example, from a UK perspective or a Canadian perspective, we need to understand the cumulative effect of lighter precautionary measures. So at one point in time, as we've heard from Stephen, you know, a harder set of measures need to be taken to achieve COVID zero. But on the other hand, once they're done, they're largely done. Over time, you know, these sort of light measures, cumulatively, I would argue, definitely have caused much higher impact in terms of mental health and suffering to the people of Ontario, in terms of domestic abuse, in terms of missed medical appointments, delayed medical appointments, cancelled medical appointments, than any of the more harsher measures, if you like, that were taken for a more limited time period in, for example, New Zealand and Australia. And I think perhaps one really can't understand the enormity of this difference until you live it. So here, my 8-year-old son goes to school in New Zealand without masks, social distancing, and he can play like any other kid could play, running, touching, hanging out with his buddies, running a triathlon at the school the other day, and so forth and so on. We can go out with our friends and family to restaurants and social gatherings, see elderly family members even without a vaccine. And, you know, after close to a year of living under the shadow of COVID-19 in Ontario, this is truly remarkable. Now, some of my colleagues and friends in Canada point to the fact that Auckland recently had 2 brief lockdowns. You know, it's kind of the argument, well, why COVID zero is not a good idea. One for 3 days and then another a week or so later of another week, because there was a concern about a couple of cases and a worry they were sort of mystery cases, whether they had come from community transmission. But the incredible difference between a lockdown in New Zealand and a lockdown in Ontario or the UK or wherever is that once the brief lockdowns are over, they really are truly over, because there is no community transmission and people can go without fear back to enjoy social, cultural, economic, and sporting life. And in contrast to Ontario over the last year, we've cycled in and out of various forms of lighter restrictions and quasi-lockdowns, lockdown lights. And as soon as the virus is somewhat controlled, immediately the government moves to open up the economy again. We even had the Opening Up Act of Ontario, spurring the infection rate and leading, it seems, inevitably for the need for yet further lockdowns. And even once the legal restrictions, the lockdown restrictions are lifted, most people in Ontario still do not rush back to restaurants or shops or businesses. These businesses are open, but they're still not flourishing. People in Ontario, unlike those here in New Zealand, can't see their elderly parents or their immunocompromised friends because of the high levels of community transmission that continue. But essential workers and the poor are sent back to work, to man shops and restaurants, to work in the meat packing plants and to travel to and from work. I want to just pause here and speak about the objective of COVID zero that we see in New Zealand and compare it to the objective they seem to have had, for example, in Ontario and Quebec and most of the bigger provinces in Canada. And their goal has never been to eliminate community transmission. The stated goal has been to tame the curve sufficiently so that we don't overwhelm hospitals. And I have to admit that at first, as when we started to deal with COVID-19, that seemed to me a reasonable objective. And but over time, I have realized that while this is superficially plausible and rational, it is simply wrong. So in Canada, particularly Ontario and Quebec, the goal of not overwhelming hospitals has permitted a lack of focus on long-term care homes and protecting personal support workers and residents through proper PPE, infection control, and testing and tracing. And 80% of Canada's carnage in COVID-19 is centered in long-term care facilities. The goal of not overwhelming hospitals means that we accept a certain level of morbidity and mortality, deaths, that is just okay. It's okay for people to die, just as long as we don't overwhelm the hospital system. And that goal has permitted close to 23,000 Canadians to die over the last year from COVID. And that goal permits, I think, or normalizes this idea that we can continue to force our healthcare workers to work through extenuating circumstances dealing with COVID-19. Well, at the same time, we, must by necessity delay, postpone, or cancel other important healthcare. So if New Zealand had followed the trajectory of Ontario, this is just to reiterate some of Ben's points, instead of the 26 deaths it would have recorded 2,400 deaths. If it had followed the trajectory of England, instead of 26 deaths, it would have recorded 10,090 deaths. Or if we spin this another way around, if Ontario had been able to mimic New Zealand's response, it would have recorded just 78 deaths instead of over 7,000 deaths. And England would have recorded just 286 deaths instead of the 111,000 people and climbing who have died from COVID-19. And I think, the scale of the differences here in terms of people who have died means that we have to interrogate very closely why all the countries in the world are not aiming for zero COVID, and what truly are the real, as opposed to the imagined barriers to such policies. And I think we need to hopefully quite quickly put to one side arguments about the economy or impacts on mental health or the poor, because I think we can truly see that, well, as I argued before, that whilst more firm lockdown measures certainly do have an adverse impact, and we do need to try to mitigate the impact on the most vulnerable, that the argument of short-term pain for longer-term gain clearly wins out in practice. To me, the only real salient argument seems to be the difficulty of closing and managing borders. And of course, it is relatively easier for islands like New Zealand or large islands/continents like Australia, Ireland to achieve this goal. It is more difficult with land borders, arguably. But even within Canada, we see there's a very different experience with COVID, with our eastern provinces of Newfoundland, Nova Scotia, Prince Edward County, and New Brunswick. They have had vastly lower rates of deaths and infections from COVID-19, and they have introduced some of the measures of an appropriate zero COVID response, most particularly closing their borders to all except returning people to the province, and having much tougher quarantine requirements for those returning. So they share land borders with other provinces, obviously, and have been able to achieve some of the benefits. So I think what I would really like us to do is to try to move past the straw man arguments put up by some that zero COVID will hurt the poor and vulnerable, and look really at what are the practical and real barriers to implementation, so that we can collectively, more and more countries in the world, move to this much better space. So thanks for your time, and I'm really glad to be part of the conversation.
Thank you very much, Colleen. Now we're going to go to Diane Abbott. Diane? Diane, I think you're still on mute.
Can you hear me now?
Yes, I can.
Very good. Well, it's a pleasure to speak at this very important meeting and make the case for a zero COVID strategy. The British Prime Minister Boris Johnson claimed yesterday that we might face a third wave because of what was happening in Europe. But Professor Christina Padgell of Independent Sage has used some very colourful language to dismiss that claim in her Twitter feed. She said that the so-called Kent variant clearly started here in Britain and is now ravaging Europe. As that wave started here, if it now washes back here, it will be the fault of this government's policies once again. The real risk is that we will have an endless cycle of lockdowns and easing with no end in sight, because vaccines alone are not a silver bullet. Sage's advice to government is that this easing is likely to lead to another 30,000 deaths. Meanwhile, the virus continues to mutate in all countries that refuse to suppress it, which is what viruses will do. But we hope that we have shown you tonight that it doesn't have to be this way. Other countries have employed maximum suppression and have achieved zero COVID, and Britain could do it too. Our next meeting will be after the break on April the 20th. Then we will examine who has been hardest hit by the virus: workers, the poor, Black and ethnic minority persons, disabled people, and the elderly amongst them. So I want to thank our chair. I want to thank all of our excellent speakers this evening, and thank you all for attending. I hope to see you all again on the 20th. Thank you.
Thank you very much, Diane. We're now going to go straight to our last few speakers for this evening. Our next speaker is Yanne Bryan, who is the president and founder of New England Complex System Institute and formerly at Boston University. He's a key member of the Zero COVID USA, and Yanne will outline the current pandemic situation in the US and that the vaccination program is not enough to prevent the spread of new mutations. Yanne.
Thank you. Let me just start. It's been clear from the discussion, but I think it's worth emphasizing again that there was just, in some sense, there was a fundamental mistake made at the beginning a year ago in the outbreak response in much of the world, with a very assumption that we couldn't eliminate the virus. And that assumption led people to focus their attention on sort of what are the trade-offs, what are the things we should do, maybe shouldn't do, rather than the intense focus on the process of elimination, identifying what needed to be done in order to get there and executing on sound plans to achieve a particular goal. And in some sense, what was present was a mirage of this idea that we can ignore the virus and it will be okay. And this mirage has over and over again attracted people to the idea that maybe we just don't have to do strong actions. And instead, what we've seen are these yo-yo lockdowns, this perpetuation of halfway measures that has made it impossible to restore the normal existence or the pre-pandemic existence that we aspire to, and that Australia, New Zealand, China, and Taiwan, and so on have achieved and have been enjoying by and large over much of the last year. Now, we have now this same perspective about vaccines. The vaccines somehow are going to give us an opportunity to get out of this. No, everyone would, of course, love that to be true, but the challenge is that with the long time of the rollout of the vaccines, there continues to be a tremendous amount of harm, both disease death and disability, the long-term effects of long COVID that we continue to discover. And as well, the variants, of course, are more rapidly spreading, more deadly, and there is some indication that they may evade the tests, making it even more difficult to control the virus. But the thing that undermines the very concept of the strategy is the fact that the virus can evade the vaccine itself. We've already seen that there is a very strong indication that people can get reinfected so that the immunity given by a particular infection is not immunity to new variants. Surely the Brazilian variant seems that it is evading much of the prior immunity. And that is a very strong indication that it may also undermine the vaccine immunity, though that still has to be seen. But there are many, many variants out there. And as the space of variants increasingly grows, the likelihood, even the certainty that there will be vaccine evading variants grows. So now we have to understand what this looks like. And indeed, the dominant expectation of the community is that we will end up with a cycling virus similar to the flu that will extend into the future indefinitely, leading to, again, the kind of death and disability that this disease is characteristic of, which is 10 times worse or more than the flu. And as virus may mutate to become worse, we have yet to see what is the extent of damage that it can cause over time. So this is the current challenge that we are facing around the world as people consider whether to rely exclusively on the vaccine. We do not know what the implications will be for the ongoing dynamics entirely, but there is a fairly strong indication that we will be in ongoing problems with this virus into the future, unless we can go back and make the strategic choice of elimination, the zero COVID choice, with all of its short-term intensive and disciplined efforts, but its long-term, clearly long-term benefits, the short-term pain, if you will, for long-term gain is manifest in this context. So that's the key narrative. And it is important also perhaps to reemphasize that in the context of this outbreak, we have seen really a breakdown of the social compact, the responsibility and responsiveness of leadership to the well-being of the public has not been as manifest, of course, as we would want, but even satisfy basic criteria. And this is a challenge for the path to the future of society as a whole. How do we reestablish a caring society that enables us to overcome challenges, this and others into the future? And having gotten to the point where I'm talking about other challenges, I do think that it is important to emphasize that this is a different world than the world of 100 years ago, when we think was the previously comparable epidemic. With the global transportation the way it is, or would like to be, the risk of more pandemics is extremely high, and the ability to respond effectively to these pandemics using the dual kind of response, the generic response of social action and the specific response of a vaccine for a particular disease is important, perhaps corresponding well to thinking about the innate and adaptive immune systems, where the innate immune system is generic response that can address many diseases, and the adaptive immune system has to evolve to be able to deal with a particular one. I think those are the comments that I have for this evening. Thank you very much for inviting me.
Thank you very much, Yanir. Our next speaker is Phil Evans from another one of our fantastic trade unions, the PCS. And Phil's going to speak to us about their dispute over COVID health and safety at the DVLA. Phil.
Thank you, and thank you for the invitation. Those other speakers have evidenced this is an international pandemic, and it's far from over, as we are so interdependent. And a stop COVID strategy is what we need. But any strategy needs to be backed up in the community and the workplace. Empowering at a local level is essential, as Dr. Schneider said. And this signally has not happened at the DVLA in Swansea. With over 600 positive cases since September, it's the biggest single workplace outbreak in the country. And it doesn't seem to have been recognised by the DVLA management. In fact, they were maintaining that the infection level at the agency was only the same as the local community, and that the cases were all coming in from outside without even recognising that it's obviously a two-way street. And in fact, our infection rate at the agency was probably 5 times the local infection rate. So although some measures have been introduced in late summer as we were asked to return to work, they clearly have not been enough. And this has meant that a lot of the members have been really very, very concerned about their health and safety. And in December, where I work at the contact centre, there are around 1,000 staff based at the contact centre. At the main site, there are about 5,200. There's 6,300 staff approximately in total at the DVLA in Swansea. There were 21 positive cases in a 2.5-week period at the contact centre alone. And obviously that was very frightening. There was a short break over the Christmas period, so that there was no one going in to work then, but nothing changed when we had to go back to work in the new year. I, for one, refused to work in those circumstances and have managed to be able to be reassessed as to my risk level, and am now working safely, fortunately, at home. But many of my colleagues are not. And the management have not engaged with the PCS union fully over the measures that are required and what we need to do to prevent this number of cases continuing. They just keep insisting that everything that has been done is sufficient, and that it was fine from September. However, lots of things have changed. Seating arrangements were found not to be adequate and were changed, and we were told again that they were fine. This was again proven not to be the case, as they had to remove in February over 330 desks from use in the agency because they were not properly distanced. The screening is totally and woefully inadequate, especially given that the Kent variant is apparently more easily transmitted by particles rather than droplets. It's caused the situation to come to such a head that the PCS have then instigated a ballot about strike action, and we achieved over the 50% requirement of people voting, which was a major achievement within the whole union system, and it does go with Helen's comments as well about that. But yeah, so we're about to take strike action if the agency won't talk to us and try and resolve it together. So yeah, thanks for that. That's where we are, but action will work. Thanks.
Thank you very much, Phil, and our solidarity with the PCS union, the DVLA. Now, our final speaker this evening, and certainly not the least, is Vicky van der Tocht, who is based in the Netherlands and represents the International Zero COVID Alliance. Vicky will be bringing an international comparative perspective to the issue of COVID policy, which is sorely lacking in this country, and will focus on different countries' policies re schools, the treatment of disabled and elderly people, and issues around social security. Vicky.
Thank you. Yes, late last year, I founded the Zero COVID Alliance, which is a worldwide umbrella platform that creates and supports zero COVID efforts around the world, and to amplify the voices of those who speak out in favor of a change of strategy. So over the last year, scientists, community leaders, activists from around the world have come together to help put an end to this pandemic as fast as possible, including multiple groups from the UK who reached out to us for help. They all united over their shared goal of making their country safer during the course of this pandemic. Tonight, I would like to share a little bit about how different groups within society have experienced this last year, both in the UK and around the world. So this last year has had an enormous impact on all of us, but it's clear to see that it has hit some groups within society harder than others. So people with underlying conditions first heard that they were going to be shielded, that they were going to be protected from this virus. And from the moment this concept was first introduced, it was evident that the practice of shielding is highly impractical. So how impractical it really is becomes clear when looking at the worldwide figures for pre-existing conditions. Estimates suggest that 1 in 5, or around 22% of all people, has a pre-existing condition. It's simply impossible to shield 22% of all people sufficiently from this virus. The list of patient groups that would be shielded was also incomplete. It did not cover a multitude of rare diseases that puts people at risk for developing severe COVID and possible death from COVID. These patients were left to fend for themselves throughout this pandemic, both in the United Kingdom as in other countries throughout Europe and all over the world. A large part of them saw no other option than to isolate themselves from the outside world entirely. A large group of people with underlying conditions has therefore been shielding for over a year now, while the country opened up and closed down again, then opened up again and closed down again, without it ever being safe enough for them to return to normal life. They were left feeling isolated, locked away, as the policy created an us versus them mentality. This, combined with the stories about the do not resuscitate orders for people with learning disabilities, made this a truly terrifying situation for some. The list of people at higher risk of developing severe COVID also did not include children, and therefore children were not deemed a group that should be properly protected from this virus. The consequences of that line of thinking can be seen in the decisions that were made around schools. Schools were to be kept open at all costs, it seems sometimes. How to sustainably keep them open was much less a topic of discussion. Mandatory in-school attendance prevented both teachers and parents, even those with underlying conditions, from being able to decide for themselves what level of risk they were willing to take regarding the health of their families. Some decided to keep their children at home, but were met with fines and threats of prosecution. It's evident by now that to safely reopen schools, there need to be proper preventive measures in place, including mandatory mask wearing, and not just in the hallways, but also in the classrooms and canteens. There needs to be proper ventilation and social distancing, and regular mandatory testing of all students, and a suspension of mandatory in-school education for those who prefer not to send their children to school during the course of the pandemic, with access to quality distance learning programs. Over the last year, we've heard a lot about the possible negative effects of lockdown measures on the mental health of children. We hear much less about what effects unsafe schools has had on them. While it's only normal that this pandemic has an effect on children, as it also has on adults, the effects of measures are in no way comparable to what a child goes through when they pick up the virus at school and subsequently bring it home and infect their parents or grandparents. A child should never have to carry the burden of feeling responsible for their family member getting sick or possibly dying from COVID, especially as they don't get the proper tools to prevent this from happening. The same can be said for healthcare workers, especially in the beginning of the pandemic. And even to this day, healthcare workers haven't been properly protected against this virus. They were exposed to an increased level of risk of catching this virus, often without adequate levels of PPE, which resulted in a high amount of positive cases and also a high amount of long COVID with healthcare workers. And while they work tirelessly to offer care to every single patient, they also, the group of healthcare workers who go on to have long-term symptoms from COVID, now these healthcare workers have long COVID and they're unable to return to full-time work. And with them, many others are suffering from the same fate. While many countries don't monitor patients after they test positive, the Office of National Statistics does have numbers. And they talk about 9.8% of all patients that go on to have symptoms for at least 3 months. With numbers this high, it's evident that long COVID is really a hidden health crisis of this pandemic, and it is likely to have an enormous impact on society for many years to come. A lot of patients who have been ill since the first wave are still sick to this day, and in many instances without access to an effective treatment. And it is therefore of the utmost importance to acknowledge the severity of the problem and to invest in research into therapeutics and possible treatments for the condition. I just wanted to share some of the stories with you tonight. I have to wrap up, unfortunately. But some of these stories clearly show that there's a need for a different approach. And with the zero COVID approach, we can assure everyone's safety, not just of those who can afford to stay at home. So because I have to wrap up, I will just like to end with the following statement. Within a civil society, everyone's health matters, or otherwise no one's health matters. And it is time we show that everyone's health matters by implementing a strategy that actually protects everyone, young and old, from both severe initial disease and long COVID. Thank you.
Thank you very much, Vicky. And I think all that's left for me to say is thank you to all of our speakers from all over the world in all of their time zones on behalf of the Zero COVID Coalition. It's been a really great meeting, and I hope it's really reiterated the point that the only way we will be able to fight this global pandemic is with global cooperation and learning from each other. Just a quick reminder about our next public meeting, which is on the 20th of April, and we'll be focusing on those hardest hit by the crisis, including workers, Black, Asian people, and disabled people, and all those who've had their civil liberties trampled throughout this particular time. Thank you all very much for your time, and have a good evening.